Good evening, everyone. Welcome you all for the IPNA endorsed webmaster series. Today into webinar 18. Today we have two eminent personalities, Dr. Manisha Sahay and Dr. Mehul Shah, who will be talking on Barter Syndrome and renal tubular acidosis. The first speaker and the chairperson for the day is Dr. Manisha Sahay. And Dr. Manisha Sahay is a professor and head department of nephrology at Osmania Medical College, Hyderabad. And she serves a lot of prestigious positions. She's a vice president of Indian Society of Nephrology. She's also editor-in-chief for Indian Journal of Transplantation. She's a council member of International Society of Nephrology. And she's a chairperson for South Asia and Regional Board. She's an executive committee member of Indian Society of Organ Transplant, and she's received more than 13 gold medals, national gold medals in nephrology 2003. She has got a lot of publications, national as well as international. It's placed more than 100. And last but not the least, she's also examiner for DNB and DNB and DM for and MCI inspector. Over to Dr. Manisha Sahay.
So thank you, Dr. Ganesan, for that introduction. So I'll be talking, and I thank IPNA for this opportunity, and I thank Dr. Ganesan for organizing the whole program. So today I'll be talking about Barter Syndrome. So today we'll be talking about the tubular disorders. I'll be covering Barter Syndrome, and Dr. Mehul would be covering the renal tubular acidosis. So Barter syndrome is not very common, but we need to know about it because diagnosis is important. Otherwise, it can lead to morbidity as well as mortality. So I start with a case which we received in our hospital, a 4-month girl child. Parents were complaining of failure to thrive. The child was admitted with dehydration in the present episode, and they reported previous 2 such episodes for which she was hospitalized elsewhere. The parents also complained of excess urination. The child used to pass urine many times a day, though it was not clearly quantified. On history, she was a product of consanguineous marriage, and the parents reported the first pregnancy, where their mother reported that they had IUD at 9 months, and history of polyhydramnios was there in the first pregnancy as well. And these were the investigations she brought to the hospital. Hemoglobin was 14, creatinine was 5, and potassium was 2.4, and bicarb was 28. So we had a child with failure to thrive, not doing well since birth. Similar family history in another child which had ended in IUD. Polyhydramnios was there for that child. And this child was not doing well, having repeated episodes of dehydration. And in addition, the lab parameters showed hypokalemia, and she had a high bicarbonate. So now, could this be Barter syndrome? So with this history, when we have a child with failure to thrive with some pointers towards the renal etiology in the form of polyuria, and some metabolic disturbances, for example, hypokalemia and metabolic alkalosis, we can think of some renal disorder. I'll be discussing that later. And one possibility could be Barter syndrome. So now we'll discuss this child later, but coming to Barter syndrome, this syndrome was described in 1962 by Barter et al., where they have described hyperplasia of juxtaglomerular complex with hyperaldosteronism and hypokalemic alkalosis. This is a rare disorder. As you can see, it affects 1 in of a million population across the world. Now about tubular disorders, we know that we have different segments of the nephron, the proximal tubule, we have the thick ascending limb, we have distal tubule, and the collecting duct. And where does this Barter syndrome occur? So Barter syndrome, as you can see in the figure, it is a disorder of the loop of Henle. We have other tubular disorders as well, and most of them present with either polyuria or with acidosis or with alkalosis or with electrolyte disturbances in the form of hypokalemia or hypomagnesemia or hypocalcemia, so on and so forth, depending on which segment of the nephron is involved. So for example, disorders affecting the proximal tubule, they cause acidosis, phosphate loss, glucosuria, and amino aciduria. And this is one of the areas which my co-speaker would be talking about. This is one of the causes of renal tubular acidosis. My talk deals with Barter Syndrome, which is a disorder of loop of Henle, and the disorders affecting loop of Henle generally present with alkalosis, hypokalemia, and calcium disturbance, hypocalcemia and hypercalceuria, because calcium is absorbed in the thick ascending limb. Then there are disorders of distal tubule. These also present with alkalosis, potassium loss, and here we have magnesium loss as well, because magnesium, in contradistinction to calcium, is predominantly absorbed in the distal tubule. And here we have disorders where you have hypokalemia, alkalosis, but you have a low magnesium. For example, Gitelman syndrome. And then we have disorders of the collecting duct. In collecting duct, we have two types of cells. We have the principal cells, where we have the ENaC channel, and the disorders affecting the ENaC channel and aldosterone, they result in alkalosis, hypertension, so on and so forth. And the disorders affecting the intercalated cell, they result in acidosis. So this is distal tubular acidosis, which my co-speaker would be talking about. So this gives a bird's eye view of different tubular disorders. One thing is common in all of them. Generally, they're present with polyuria, they're present with electrolyte disturbances. So this child, when such a child comes to us with failure to thrive, with polyuria and some electrolyte disturbances, our focus automatically shifts to the kidney. And now we need to analyze which part of the kidney is involved. So coming to Barter syndrome, as I said, it is a disorder of the thick ascending limb. And this picture shows the picture of the thick ascending limb. You can see the pink ones, which are the transporters here. The main transporter is NKCC, that is sodium potassium 2 chloride transporter, which is responsible for sodium absorption in the thick ascending limb. Then you have a potassium channel, a apical potassium channel, ROMK. Then basolateral side, you have the sodium potassium ATPase, which is present in the basolateral aspect of all the tubular cells of the nephron. This is the energy producing transporter of the cells. And then you can also see a chloride channel. And then you can see a calcium sensing receptor. So there are 5 molecules which are, or 5 proteins which are located in the thick ascending limb. And all of them directly or indirectly contribute to the sodium absorption in the thick ascending limb. And this function is disturbed in Barter syndrome. So this Barter syndrome can affect any of these 5 proteins located in the cell of thick ascending limb. So what is the pathogenesis? It's a genetic disorder. And as I said, in a nutshell, there is defective salt resorption in the thick ascending limb of loop of Henle. And this defective salt absorption, as I said, can be because of disturbance of any of these 5 proteins. But the net result is the same. Because of loss of salt, there is volume depletion, there is activation of renin and secondary hyperaldosteronism. This we should understand. Because there is less absorption of sodium in thick ascending limb, the sodium passes on to the distal tubule. And in distal tubule, the sodium is absorbed and there is exchange of sodium with potassium as well. Then, because of decreased chloride absorption, because of the defective function of NKCC, you have loss of chloride in the urine. And this loss of chloride increases the intraluminal negativity. The intracellular positivity, the intraluminal positivity is responsible for driving the calcium absorption, which I'll be dealing with in the next slide. And as a result, there is loss of calcium. The absorption of calcium depends on the intratubular positive voltage. But because chloride is lost, now you have chloride, which is a negative charged ion in the tubular lumen, the intraluminal potential becomes negative, and as a result, this leads to decrease in calcium absorption. And then there is some problem with the neutralization of citrate because you have intracellular alkalosis, and this neutralizes the citrate, and there is decreased citrate production and secretion in the tubule. So it may look a bit complicated, So just to understand, the basic defect is a loss of sodium and chloride. And what happens here, this is a normal lumen and a normal thick ascending limb cell. And you can see that the intraluminal potential is plus 6 to 25 millivolt. But in Barter's, because of loss of chloride and high chloride in the tubular lumen, the luminal voltage becomes negative. So normally this positive voltage drives the calcium inside the inside the cell and in the blood. And because of this negative voltage, calcium absorption decreases. There is a decrease in magnesium absorption as well, but as I said, magnesium absorption is typically a function of distal tubule, and that is normal in Barter syndrome. So more of calcium is lost in urine. Why magnesium is normal in Barter syndrome? Because though magnesium is absorbed to a certain extent along with calcium paracellularly in the thick ascending limb, the majority of magnesium absorption is in the distal tubule. And this is intact in Barter syndrome. This is defective in Gentleman syndrome. So Gentleman, you have loss of magnesium in urine. In Barter's, magnesium is generally not lost in urine because of normal function of the distal tubule. And why do we have hypokalemia and alkalosis in Barter syndrome? This is because of many reasons. The predominant reason is because of volume depletion, there is rise in renin, increase in aldosterone. And what does this aldosterone do? It acts on the ENaC channel, the principal cell, and also on the intercalated cell in the collecting duct. And what it does is, it helps in absorption of sodium, it helps in secretion of potassium. So potassium is lost in the collecting duct in the urine, and it also stimulates the H plus ATPase on the intercalated cell, and as a result, much of hydrogen is also lost in urine. So these three pictures explain to us that because of loss of sodium, chloride, and potassium transporter function, it leads to a variety of other abnormalities, including loss of calcium in urine, loss of hydrogen in urine, and also loss of potassium in urine. And that's why we have the metabolic abnormalities, metabolic alkalosis, and we have hypokalemia. So we have talked about the biochemical defect, what happens in the Barter syndrome. In the other varieties of Barter syndrome also, the net result is loss of sodium, chloride, and potassium in urine. So what are the different types of Barter syndrome? I said 5 proteins are there in the cell, and the defect of NKCC, the sodium potassium chloride cotransporter, is called Barter syndrome type 1. The defect in the potassium channel is called Barter syndrome type 2. The third one is a defect in the basolateral chloride channel, that's called Barter syndrome type 3. Barter syndrome type 4 is because of a defect of Bartin, which is a subunit of the chloride channel. So this is called Barter syndrome type 4. Now we call it Barter syndrome type 4A. So type 4A is because of Bartin related defect. The Barter syndrome type 4B is because of the defect of chloride channel, both components Ka and Kb. So this may look a bit confusing, but if you remember this slide, you'll be able to understand the Barter syndrome better. So we have talked about these 5 varieties, 1, 2, 3, 4A and 4B. Then we have MAGED, M-A-G-E-D, and this is another 6th variety of Barter syndrome, which is transient. And the last variety, the 7th variety, is because of the involvement of calcium sensing receptor, which is present on the basolateral membrane. And this is inherited autosomal dominant fashion, and it is associated with hypoparathyroidism and hypocalcemia. So we have 7 types of Barter syndrome in all. So genotypes, you can have 7 types of gene defects. And these are the 7 types which I was talking about. Type 1, this is again, as I said, NKCC, which you remember from the previous slide. You can see that if you want to understand this table, there are certain common features in type 1, type 2, type 3 is different. Type 4 and MAGID. So type 1, 2, 4 and MAGID, they present early in neonatal period. They are associated with polyhydramnios, polyuria, prematurity as well. And the hyperprostaglandin E levels are seen in 1, 2, and 4 varieties. The type 3 does not present in the neonatal period generally. Similarly, the calcium sensing receptor also presents later, not in the neonatal period. So out of the 7 varieties, 5 present in the neonatal period, type 1, 2, 4A, 4B, and MAGID. How do we differentiate among these 5 neonatal types? Type 1 and 2 are associated with nephrocalcinosis. Type 4, A and B are associated with generally sensory neural deafness. The MAGID type, it is very transient. It presents early, but it disappears early as well. The type 3 is called classic Barters, and as I said, it presents a little bit later in life, in childhood. Similarly, the calcium sensing receptor, which is autosomal dominant variety, also presents slightly later in life. So 3 and calcium sensing receptor present later in life. So this table you should repeatedly remember. 1, 2, 4 in neonatal period, and those which present in neonatal period present with polyhydramnios, polyuria, and nephrocalcinosis in 1 and 2. The 4th one has sensory neural deafness. They may be overlapped, but this is the most common manifestation. So this was a paper in C. Jason where they showed this MAGID variety that contributes to a very small fraction of the total number of Barter syndrome. Most common types of Barter syndrome are from 1 to 4. The 1, 2, 3, and 4 are the common ones. Fine, so we have understood that Barter syndrome is because of a defect of thick ascending limb, and any of the 5 proteins there can be defective. We also understood that there are 7 types as per the genotypic classification, and we also understood that 1, 2, and 4 present early, 3 and 7 present a little bit later in life. Now, how do the patients of Barter syndrome present? So we have genotypic presentation, the 7 types. Similarly, all these can present in 3 predominant ways. So we have 3 main phenotypic presentations. As I said, antenatal presentation, and is now clear that 1, 2, 4 and MAGID present antenatal or neonatal. Polyhydramnios at 30 weeks generally, neonatal polyuria, prematurity, nephrocalcinosis, especially in type 1 and 2, and deafness in type 4. And typical facies may be seen, which I'll be showing in the next slide. And as I said, you now remember which genotypes are associated with antenatal presentation. Childhood presentation with poor growth, repeated dehydration, thirst, polyuria, cramps, constipation, and salt craving occurs generally in type 3 or classic Barters, as also in the autosomal dominant calcium sensing receptor mutation type of Barters. And less common variety of Barter, which may occur in adolescence, mimics Gitelman syndrome, again presents in a subtle manner with cramps, fatigue, carpopedal spasms, etc. Generally, type 3 Barter may present like this. So we have 7 genotypes and 3 main phenotype presentations. And this presentation, this facies is called Barter's facies, which is associated with a neonatal presentation: triangular face, prominent forehead, large eyes, protruding ears, drooping mouth. And as I said, generally seen in the neonatal variety. So as I said, in the neonatal variety, one of the presentations may be polyhydramnios. Now, polyhydramnios, we have a variety of causes of polyhydramnios, and Barter's is just one of the causes of polyhydramnios, one of the rare causes of polyhydramnios. So history of polyhydramnios alone does not suggest Barter. You have to look for other features as well. Polyhydramnios may be because of fetal defects generally, because of maternal diabetes, so on and so forth. Barter's is only one cause of polyhydramnios. And if polyhydramnios is associated with metabolic alkalosis and hypokalemia, that is the pointer towards Barter syndrome. Similarly, polyuria alone, you may suspect Barter's, but remember you have so many causes of polyuria. You may have polyuria because of solute diuresis. You may have polyuria because of water diuresis. And water diuresis typically you see in diabetes insipidus. Solute diuresis you have in so many other conditions. In Barter's also you have loss of sodium and chloride in urine. And again, if polyuria is associated with hypokalemia and metabolic alkalosis, you can suspect Barter syndrome. So polyuria alone is a pointer, but not diagnostic. Polyhydramnios alone is a pointer, not diagnostic. Again, nephrocalcinosis. Some children come with nephrocalcinosis. Are all of them Barter syndrome? No. Again, you have many causes for nephrocalcinosis. Tubular disorders definitely are important cause. But again, you have hyperprostaglandin E syndromes. You have vitamin D intoxication. You have sarcoidosis, tuberculosis, hyperparathyroidism. You have hypercalceuria. So many other conditions which can cause nephrocalcinosis. Generally, in Barter's with nephrocalcinosis, you have again hypokalemia and metabolic alkalosis. So these two constellation of findings are important pointers towards a tubular defect involving the thick ascending limb or the distal tubule. Some children come with failure to thrive. Barter's is one of the differentials of that. Failure to thrive can be because of environmental reasons or maybe because of abnormality of any other organ system. Renal system is just one of them, and renal system may be CKD or tubulopathy. And here is where we get Barter's. Again, metabolic alkalosis and hypokalemia are present in case the child has failure to thrive because of tubular disorder. The same constellation can also be sometimes found in cystic fibrosis as well. You have multiple causes of failure to thrive, and as I said, Barter's is just one of them. So important thing, in the last 4 slides, what I'm trying to tell you, Barter can present in the neonatal period, in childhood, sometimes later in life. Important constellation of metabolic findings are helpful in diagnosis. Pointers are hypokalemia and metabolic alkalosis in the absence of hypertension. So these are some important clues where you can think of a Barter syndrome. Now, our child presented with failure to thrive, dehydration, polyuria, blood pressure was 60/40. And the parameters I told you already, metabolic alkalosis was there, hypokalemia was there, ultrasound showed nephrocalcinosis. How would you investigate this child further? So we know that whenever we have a constellation of metabolic alkalosis, hypokalemia, and normal BP, the next step is to find out the urine chloride. And if the urine chloride is high, it shows that there is a renal loss of chloride. And this occurs in Barter syndrome, can occur in Gentleman syndrome, can occur with diuretic use, and also in many hypomagnesemia syndromes. If the urine loss is less than 25 milliequivalent per liter with the same constellation of findings, metabolic alkalosis and hypokalemia, then it is extrarenal loss of chloride. Common causes are cystic fibrosis, where the chloride loss occurs to the skin, bulimia, pyloric stenosis, where the chloride loss occurs from the upper GIT, and sometimes congenital chloride diarrhea. So these are the extrarenal causes of chloride loss, where you can have a similar metabolic alkalosis, hypokalemia with failure to thrive. But urine chloride helps in differentiating whether it's a renal defect or it's a defect outside the kidney. Same constellation, as I said, can occur with hypertension. This is not the case here. We are having the child with normal blood pressure. If the child were to have a high blood pressure, then we would be thinking of Horn syndrome, apparent mineralocorticoid excess, so on and so forth, which I won't be discussing further. So here we have a child with metabolic alkalosis, hypokalemia, normal blood pressure, and a high urine chloride. As I said, if the urine chloride is low, we think of extrarenal causes. History helps in diagnosing these causes. Our child did not have any of these histories. And you can do a genetic test for cystic fibrosis and sweat chloride as well. So anyhow, our child had a high urine chloride loss, and it was a genetic defect probably a defect in the kidney. So renal causes are Barter's, Gentleman, diuretic use. These are the predominant causes. There may be other rare syndromes of hypomagnesemia, Gallner syndrome, so on and so forth as well. So commonly, we think of common things first. Diuretic use is common. So complete history should be taken. The characteristic feature of chloride loss in diuretic use is it is not constant. Sometimes it is high, sometimes it's low, depending on what time the diuretic was taken. And in addition, you can look at urine levels of diuretic as well. So this child did not have any history of diuretic use. So we were thinking of either a Barter syndrome or a Gentleman syndrome. Common possibilities. This child had a urine chloride of 35 milliequivalent per day. So our differential diagnosis probably was between Barter syndrome or a Gentleman syndrome. Barter syndrome is like a loop diuretic, affects the thick ascending limb. The Gentleman syndrome is just like a thiazide diuretic. We know that Barter syndrome is NKCC defect or other proteins in the thick ascending loop. Gentleman syndrome is because of sodium chloride co-transporter in the distal tissue. Barter syndrome generally occurs at a younger age. Magnesium is normal, as I already explained. Urine calcium losses are high, 200 milligram per gram of creatinine, or urine calcium creatinine ratio more than 0.2. In adult, you see generally Gentleman syndrome, though there are case reports of Barter syndrome occurring in adult as well, but very rare. Here the serum magnesium is low, urine magnesium is high, and urine calcium is characteristically low. As I said, most of the calcium absorption occurs in the loop, not in the distal tissue. So what happened? What were the investigations for our patient? Some we discussed already. The urine pH was 7, specific gravity was 1.006, urine osmolality was 305, hemoglobin was 15, serum creatinine 0.3, urea was 14, pH was 7.48, bicarb was 28, electrolytes 135 sodium, potassium was again 2.4, chloride was 92, magnesium was 1.5, repeat was 1.7, urine chloride 35 milliequivalents per day, urine sodium was 104, urine calcium creatinine ratio was 0.27. Transtubular potassium gradient was 10, showing again a potassium loss in the urine. Phosphorus was normal, uric acid was okay. Prostaglandin levels were not done. Plasma renin activity was found to be high, and serum aldosterone was also found to be high. We need not routinely do these levels of renin and aldosterone, but because these cases are uncommon and we had presented it in one of the fora, we had done the complete profile. So generally ECG changes may be there, especially if the potassium is less than 3.5. You can see U waves as well. Ultrasound and X-rays should be done when you suspect Barter syndrome. Ultrasound may show nephrocalcinosis, CT may show the same findings, and X-rays also you may be able to make out the nephrocalcinosis. Renal biopsy has been described in literature, but it's not done for diagnosis of Barter's. It was done in the initial era when the syndrome was discovered, and it shows juxtaglomerular hyperplasia because of increased production of renin, proximal tubular vacuolation because of hypokalemia, chronic hypokalemia. At some case of Barter's may progress to CKD and you may find interstitial fibrosis. But as I said, biopsy is not required for diagnosis. Audiometry is done because, as I said, some patients have sensory neural deafness, and our patient had a report of bilateral sensory neural deafness. So probably we were dealing with a patient of type 4 Barter syndrome. Fine. So is genetic analysis needed in all patients who present like this? We have made some diagnosis of Barter's, clinically looking like Barter's, fitting into all the features. Probably it is type 4, but do we need to do a genetic analysis? If you do a genetic analysis, you will get the defective gene and different types of mutation, missense, frame shift, nonsense, splice, large deletions. But what does it add to the treatment? Why it's important to do a genetic analysis? This is important because many papers have shown that in Barters, there may not be any phenotype-genotype correlation. Sometimes you may completely miss the diagnosis. And this is a classical example in this paper from Orphanet Journal of Rare Diseases. The clinical diagnosis was Barters. They studied 17 children with Barters between 3 months to 6 years, all presented with hypokalemic metabolic alkalosis. The onset of the disease was between 3 months to 6 years. Like in our patient, 3 patients also had hypercalceuria and nephrocalcinosis. So fair enough, they must have thought Barters. They clinically thought of Barters, but on screening, they found that in 70%, their diagnosis of Barters was right, and CLCNKB gene was involved. But in 25%, the diagnosis of Barters was wrong. In fact, the patient has congenital chloride diarrhea in one, proven by the genetic mutation, Pendred syndrome in the other. One patient had cystic fibrosis, another had apparent mineralocorticoid excess syndrome. So clinical examination helps, but there are certain limitations. For example, congenital chloride diarrhea, urine chloride should have been low. But in this case, probably urine chloride must have been borderline and they misclassified as renal loss Barters. Similarly, cystic fibrosis, here also the urine chloride must be low normally. Here also probably they had a high urine chloride and misclassified as Barters. In apparent mineralocorticoid excess syndrome, as we discussed, hypertension is an important feature. But hypertension may be missed, maybe blood pressure may not be checked, or sometimes the hypertension develops a little bit later, and hence they had misclassified this patient also as a Barter syndrome. Therefore, genetic testing is important because clinical diagnosis is accurate in 80 to 90%, but in remaining, you may have a problem. So this is what they found. As I have already told, they had one case of congenital chloride diarrhea, one cystic fibrosis, one AME, Pendred syndrome, and the other was that CNB mutation. So this was the genetic analysis in their cohort. Another paper where they diagnosed Barter syndrome type 1 as nephrogenic diabetes insipidus. So the diagnosis was nephrogenic diabetes insipidus, but the clinical picture was looking like Barter's with some inconsistencies. Meaning in nephrogenic diabetes insipidus, you should have a dilute urine. The urine osmolality will be very low. Urine specific gravity will be low. It won't respond to arginine vasopressin. So their child also did not respond to arginine vasopressin. So finally, they ended up doing a genetic analysis. The genetic analysis showed Barter syndrome, but then why the child did not respond to arginine vasopressin, the reason was many of the Barter's children can develop a secondary nephrogenic diabetes insipidus. As you all know, nephrogenic diabetes insipidus can occur because of hypokalemia, because of nephrocalcinosis. So probably this child had Barter syndrome genetically, but because of secondary nephrogenic diabetes insipidus, you had some atypical findings. And this is another case in point where again, the child did not have clinical features of Barter's, but genetic testing showed Barter syndrome. So this genetic analysis, but report is still awaited. We have sent it through our funds, and that's the reason to the government funds, so it's getting delayed. Now, how to treat once you have diagnosed Barter syndrome? Initial treatment consists of stabilization of volume status, salt and water. That should be the first therapeutic aim. Next is potassium supplementation. So IV or oral, if the potassium is low, symptomatic hypokalemia, you need to treat with IV KCl. IV KCl is available in different percentages. Generally in India, we get 15% KCl, where 10 ml contains 20 milliequivalents of potassium. So you know the rule of the thumb that we should not give too much of KCl in a limited period of time. We should follow the norms. So roughly 0.2 millimole per kg per hour over 3 hours is a rough guideline. We should never add more than 20 milliequivalents in a liter. Max is 40 milliequivalents in a liter, but we don't add that because extravasation of potassium can cause necrosis. In this example, They have used 7.5% KCl. We use 15% KCl. 15% KCl contains like 10 ml contains 20 milliequivalents. And once the acute correction is done, you can go to oral replacement. 15 ml of hot chlor syrup provides 20 milliequivalents of potassium. Now, how do you calculate the potassium deficit? You can use a formula. The target potassium minus the patient's potassium into 0.4 into body weight. You can use that formula for calculating potassium deficit. Otherwise, you can replace, check the potassium, and again, you can give the prescription. So unlike sodium, the formula for potassium correction, you need to do the potassium again and again and modify your prescription accordingly. If there is magnesium and calcium deficiency, you need to supplement that as well, either oral or parenteral, but this is generally not required. Many of the potassium preparations contain magnesium, and that is sufficient. But remember, only supplementation of potassium lifelong is not going to take care of the hypokalemia. You have to add NSAIDs, which inhibit the PG, the prostaglandin synthesis. They are very beneficial in the first few years of life. They can be weaned later during childhood, as the patients can self-regulate their salt and water intake later on once they learn to eat and drink on their own. Which ones can be used? Indomethacin is popularly used, aspirin and ibuprofen, and we are all well familiar with the side effects. So we start with lower doses and then build up on the dose. And we use with caution in premature infants because of risk of GI perforation, necrotizing enterocolitis, pseudotumorous cerebri, and GI flu. You can also add, in addition to NSAID, potassium-sparing diuretic. We know amiloride, spironolactone, and triamtrene. They are the potassium-sparing diuretics. We have now eplerenone also available. So you can use any of them. Amiloride, it says it's preferable. Some literature favors amiloride because it blocks the alkalosis both in the proximal tubule as well as in the distal nephron. Spironolactone acts only in the distal nephron, but some papers say that spironolactone is more effective. And then triamtrene, that can also be used. So we generally use spironolactone because it's available to us. ACE or ARBs can be added. They reduce potassium loss, but they are used only as add-on therapy. Never ever use them if the child is volume depleted. They can cause AKI. We are well familiar with their side effects. So there are not much studies of adding ARBs in children. ACE inhibitors have been reported. But generally, we treat with potassium supplements and NSAIDs and with the potassium-sparing diuretics. The treatment is really lifelong. This is a summation of the treatment which we discussed. In case of growth impairment, growth hormone has been tried in such children before they attain the fusion of epiphysis. So that can be done in consultation with the endo department. Once the child is started on these chronic therapies, you need to monitor the child. Every visit, blood pressure, hydration should be checked. Annually, growth, psychosocial assessment is necessary. Labs should be checked. Electrolytes, bicarbonate, urine calcium creatinine ratio, creatinine and GFR. Annually, even bone mineral density should be checked because many of these children have hypercalceuria and osteopenia. The growth of child should be plotted on growth charts, weight as well as height. That helps us to keep track of the child's progress. The disease is not curable. Lifelong treatment is required. It is associated with significant morbidity and mortality. Can CKD occur in Barters? Yes. In one series, 10% had CKD. Causes can be chronic hypokalemia, causing hypokalemic nephropathy. FSGS can occur due to renin stimulation. Use of NSAIDs itself can cause CKD. Repeated AKIs due to dehydration and nephrocalcinosis. Other comorbidities are arrhythmias and sudden death because of dyselectrolytemia. Growth retardation is seen in almost 100%. Low bone mineral density and sensory neural deafness. Therefore, the parents also need to be counseled that it's a lifelong disease. The parents must be told not to stress the children to do strenuous exercise. They should be provided adequate volume and salt intake. They should also be advised regarding high potassium foods. High potassium means any food which gives more than 200 milligram potassium per serving. And also later on in life, they need genetic counseling because it is an autosomal recessive disease, and marriage counseling should be done so that this is taken care of in later life. Now, this is a girl child. She was doing well. She was put on potassium, indomethacin, and on spironolactone. She was doing quite well. She was gaining height and weight, and now she's on chronic therapy. So the next question would be, can girls with Barters get pregnant? So in a series, it has been shown that they delivered healthy kids if they were managed properly. But in this series, most of their children had Gitelman syndrome rather than Barter syndrome. So in this, out of 40, 30 reported normal pregnancies, which were terminated by normal childbirth. What about transplant in those who progress to CKD? So transplant is a good option if they progress to CKD. Barter syndrome gets corrected after the transplant because the new kidney is normal and it does not recur. Who can be the donor? Because it's an autosomal recessive disease most of the times, both the parents will be carriers. They will carry the defective gene. However, transplants from living, unrelated, or cadaver donors are options for patients who reach ESRD. Is there any role of preemptive transplant? Yes, that has been described in this paper by Mini-Serval group in Pediatrics 2006, where they said preemptive bilateral nephrectomies and successful kidney transplant prior to onset of ESRD was done in a child with severe Barter syndrome, and that resulted in correction of metabolic abnormalities and excellent graft function. What are some of the newer advances in this arena? So we are all well familiar with antenatal diagnosis, and especially in cases of polyhydramnios. So high chloride level in amniotic fluid is characteristic of Barter syndrome. Generally, the normal level is 107 to 109. In this, the levels are much higher. The other cause of polyhydramnios can again be diagnosed by amniocentesis, where we look at alpha-fetoprotein, other things. But in Barters, classically, urine chloride is higher than normal. Suppose you diagnose this child. Suppose this parents want to have another child, next child. Can you diagnose whether that child has Barters? Yes, in case the child has prenatal Barters and polyhydramnios is severe, the mother can be started on NSAIDs and can be treated with NSAIDs till 31st week. After that, you have to stop the NSAIDs. If you are using NSAIDs, you have to monitor for tricuspid regurgitation. NSAIDs should be avoided beyond 32 weeks because they cause early closure of PDA. In addition, intermittent drainage of amniotic fluid can also be done. And there are certain newer advances where they are talking about molecular chaperones, which can help in delivery and insertion of fully or partially functional proteins into cell membrane. But again, it is only experimental. So ladies and gentlemen, we have some case series on Barters from Chennai, where they had done case series of around 7 children, where they have not done a genetic analysis in all of them, but the children did well. The last slide, we should remember it's a rare disorder. Diagnosis is important. We should suspect if polyhydramnios, polyuria, repeated dehydration, and failure to thrive. I also told you about metabolic alkalosis and hypokalemia along with this combination. High urine chloride suggests Barters, along with increased urine calcium. Genetic testing is advisable and long-term follow-up is required. Barter syndrome, ladies and gentlemen, is a full-time job. You have to manage it all day long, not only all day long, all lifelong. So thank you for a very patient hearing. Remember, Barter syndrome, you can call it a congenital loop diuretic, and that's how you can remember Barter syndrome. So thank you for the opportunity.
Thank you so much, ma'am, for the excellent presentation, for taking us all into the depth of Barter syndrome. It was an excellent presentation. And the next speaker for the day is Dr. Mehul Shah.
Yes.
1 second, sir. Dr. Mehul Shah is a consultant pediatric nephrologist at Apollo Health City and Little Stars Children's Hospital, Hyderabad, and his special interest is renal tubular acidosis and antenatal renal anomalies. And so as per his interest, he is the apt person to teach about all about renal tubular acidosis. Over to Dr. Mehul Shah. Thank you, sir. Thank you for accepting our webinar series.
Thank you so much, Dr. Ganesan. So at the outset, thank you, Dr. Ganeshan and Dr. Namalwar Garu, as well as IPNA for the wonderful planning of this IPNA webinar and for the opportunity to be part of it. Dr. Manisha Sahay has explained in great detail about the pathogenesis and pathophysiology of Barter Syndrome and has made my work little easy. Moving on to the other common renal tubular disorder, I will be talking on renal tubular acidosis. So, as we know that metabolism of, one second, sorry, metabolism of macronutrients produces acid in the body, while metabolism of carbohydrates and fats leads to production of volatile acid, namely carbon dioxide, which is then excreted by the lungs. Metabolism of proteins leads to production of non-volatile acid, which is hydrogen, namely the sulfuric acid and the, I'm sorry, I'm not able to get my, which leads to production of non-volatile acid, mainly sulfuric acid and phosphoric acid. Approximately 1 to 1.5 milliequivalent of acid per kilogram per day is generated by protein metabolism. In children, additional 1 milliequivalent of acid per kg is contributed by growing bones. As calcium carbonate is incorporated into the growing bones, hydrogen is exchanged into the extracellular fluid. So approximately 2 to 3 milliequivalents of hydrogen per kilo per day is generated in a growing child. This acid which is generated is initially buffered in the intravascular compartment by the bicarbonate buffer and subsequently by the intracellular buffers, mainly the proteins and the phosphates. The kidney plays an important role in taking care of the hydrogen which is generated by metabolism of the proteins. It not only secretes hydrogen, but it also regenerates the bicarbonate which was utilized in buffering of the hydrogen. So there are two important processes at two different sites in the kidney which take part in acid-base homeostasis. The first is the reclamation of the filtered bicarbonate, which predominantly takes place in the proximal convoluted tubule, about 80 to 85%, and remaining about 14 to 15% takes place in the distal tubule as well as the cortical collecting duct. In health, less than 1% of filtered bicarbonate is excreted in the urine. Close to 99% is reabsorbed or reclaimed. The second important process of the kidney is in secretion of the generated hydrogen, which takes place in the distal nephron, specifically the alpha intercalated cells of the distal of the cortical collecting tubule. As Albert Einstein once said, the most beautiful thing we can experience is the mysterious. It is the source of all true art and science. Who else but the renal tubule that correlates so well with this statement? The renal tubule was and is indeed mysterious. It's a work of true art and science with the complex yet harmonious regulation of various salts and water. So moving on to renal tubular acidosis, RTA is a diverse group of renal tubular disorders that involve either a defect in proximal bicarbonate reabsorption or a defect in hydrogen secretion or both while the GFR remains near normal. This is an important thing because in a child who has got chronic kidney disease and metabolic acidemia, we should not be diagnosing RTA. That would be acidemia of chronic kidney disease. It is associated with hyperkalemic, normal anion gap, metabolic acidemia, and often hypokalemia, especially with types 1 and types 2 renal tubular acidosis. It was first described in 1935 by Lightwood and designated as RTA in 1951 by Pines et al. There are three main subtypes of RTA. Type 1 or distal renal tubular acidosis, which is due to defect in the distal nephron hydrogen secretion. Type 2, because it was detected and labeled after type 1, it is proximal RTA, which is isolated, which is rare, but more commonly a part of generalized tubular dysfunction called as renal Franconis syndrome. There's a defect in the proximal bicarbonate reabsorption, and type 4, which is because of aldosterone hyporesponsiveness related to deficiency or resistance. So type 1, type 2, type 4. There is type 3, which is called as a mixed RTA, though many authors do not use this terminology anymore, but it is due to defect in both the proximal and the distal acid secretions. It's a combination of proximal and distal, which is called as type 3 renal tubular acidosis. So the common clinical features of RTA are failure to thrive, predominantly in physical milestones, polyuria and polydipsia. Often these children have constipation because of chronic volume depletion and hypokalemia, vomiting because of metabolic acidemia and hypokalemia, weakness because of hypokalemia. So this factor contributes to the delay in physical milestones. Some children may present with non-healing rickets after 1 or 2 doses of vitamin D therapy, and occasionally we may have a baby boy with PUV presenting with recurrent UTIs and poor urinary stream and having associated type 4 renal tubular acidosis. Please remember, the closest differential for renal tubular acidosis in a young child is chronic kidney disease. This could be either a primary hypodysplastic kidney or secondary to PUV in baby boys. So if there is a persistently elevated creatinine, we need to think about chronic kidney disease and not RTA causing chronic kidney disease. There are different tests for urinary acidification, which I'm not going to go through in detail, but just to enumerate: urine pH, urinary anion gap, ammonium chloride loading test, urinary to blood PCO2 gradient, and fusamide challenge test. There are a number of them. Some of them are easy to test, some of them are difficult, but for practical purpose, urine pH and urine anion gaps are simple and effective way of classifying the renal tubular acidosis. Our approach should begin with looking at a urine sample specifically for pH, specific gravity, protein, and sugar. Urine pH depends upon the acid-base balance of the blood and also depends upon the diet which we are consuming. In general, an alkaline urine is seen when there is diarrhea, distal renal tubular acidosis, chronic hypokalemia, or protease infection. So there are a number of other reasons where we can get urine pH more than 6.0. Specific gravity, most children, I would say not most, all children with renal tubular disorder will have an hypoosmotic urine which is less than 1010 because of chronic hypokalemia leading to secondary nephrogenic diabetes insipidus, as was mentioned by Dr. Manisha Sahay. Presence of proteinuria and glucosuria would often guide us towards the diagnosis of renal Fanconi syndrome. An important point for us, especially the postgraduates, to remember is if we have a urine specific gravity which shows concentration of 1025 or 1030, it indirectly rules out a renal tubular disorder, because all children with renal tubulopathy will have hypoosmotic urine and the specific gravity will be 1005 to 1010. So a child with urine specific gravity of 1020 and above suggests good concentrating ability and a very, very low likelihood of a primary renal tubular disorder. Let's move on to urinary anion gap. This is a very effective tool to classify the type of renal tubular acidosis. All we need is to measure the urinary electrolytes, and the electrolytes which can be measured in the urine are sodium, potassium, and the chloride. It is an indirect index of urinary ammonium concentration. The urinary anion gap is the difference of the cations minus the anion. And this is normally close to 0, plus minus 5, that is minus 5 to plus 5. A positive urinary anion gap, meaning sodium plus potassium greater than chloride, would indicate that there is low urinary ammonium, and that is seen with distal RTA because there is a defect in hydrogen ion secretion in the distal nephron. Conversely, a negative urinary anion gap, meaning minus 5, minus 10, minus 15, would indirectly tell us that there is sufficient amount of ammonium in the distal nephron, and the distal nephron is intact. This is seen either with diarrhea or with proximal RTA. So positive urinary anion gap, deficient ammonium, negative urinary anion gap means there is sufficient ammonium in the distal nephron. So what are the basic tests which can be done to evaluate a child with RTA? All of them are quite simple, gives us a lot of information. It should begin with a complete urine examination where we should be able to know the specific gravity, pH, presence or absence of protein and sugar. A venous blood gas, we do not need arterial blood gas because we are not looking at the oxygenation part of the blood gas. Renal function test to rule out established chronic kidney disease, serum electrolytes to look for biochemical features of rickets, and certainly an ultrasound abdomen to look for kidney size, presence of hydrouretronephrosis for obstructive uropathy, and nephrocalcinosis. So this is a simple test which can be easily obtained and gives you a lot of information. To further define whether it's a proximal or a distal RTA, we need to get additional urinary studies, urinary electrolytes to estimate the urinary anion gap, urinary calcium creatinine ratio to look for hypercalceuria, and to look for proximal renal tubular disorder, we need to look for urine protein creatinine ratio, fractional excision of phosphorus, and this in essence will give us most information. In most children, we do not need to do a urinary acidification test. Based upon the preliminary data, we should be able to conclude whether it's a distal RTA or a proximal renal tubular acidosis. If required, one can do a ammonium chloride loading test. To further identify the etiology of renal Franconis syndrome, we may need to get an eye exam for cysteine crystals, blood aminoacidogram, and nowadays with mutation analysis being freely available, that will confirm the primary etiology of renal Franconis syndrome. If we are suspecting type 4 RTA, we obtain plasma aldosterone level, cortisol and 17-hydroxyprogesterone to look for salt wasting CAH, and MCUG if we are suspecting posterior urethral valves in a baby boy. Again, to reaffirm, in most children, the baseline test and additional urinary electrolytes and solute excretion is sufficient for us to come to a diagnosis of subtype of RTA. So moving on to the specific types of RTA, we will begin with type 2 RTA, which is the proximal renal tubular acidosis. As we know that proximal renal tubule is a very leaky tubule, and it is responsible for reabsorption of 65% of the filtrate and almost 80 to 90% of the solutes. Hence, it is called as the workhorse of the kidney. The different solutes, the glucose, the amino acids, the phosphates, the citrates, are reabsorbed along with sodium through the sodium solute symporter. The basolateral sodium-potassium ATPase pump, which drives 2 potassium inside the cell and 3 sodium outside the cell, creates a negative voltage because 3 more positive charges are leaving and less positive charges are entering, and it lowers the sodium concentration. So both these factors leads to a favorable electrochemical gradient across the luminal membrane, allowing sodium to go from lumen inside the cell. And along with sodium, there are other solutes which keep on going inside the cell. So the sodium solute symporter on the luminal membrane is a secondary active transporter responsible for reabsorption of a number of solutes in the proximal tubular filtrate. Coming to specific bicarbonate reabsorption, as we know that 85% of bicarbonate which is filtered across the glomerular capillary membrane is reabsorbed in the proximal convoluted tubule. How does this happen? This is a schematic diagram of a proximal convoluted tubule cell. On my left is the luminal membrane, on my right is the basolateral membrane. This is one cell, and that's a cell intercellular junction. Carbon dioxide is hydrated inside the cell in presence of carbonic anhydrase isoform 2 to form bicarbonic acid, H2CO3, which spontaneously dissociates into hydrogen and bicarbonate. This hydrogen is secreted across the luminal membrane, either in exchange for sodium by the sodium hydrogen exchanger isoform 3, to a less extent by hydrogen ATPase pump, hydrogen in the luminal membrane combines with the filtered bicarbonate to form H2CO3, which now dissociates in presence of carbonic anhydrase isoform 4 to form carbon dioxide and water. Carbon dioxide diffuses freely inside the cell and then continues the cycle. The bicarbonate, which is separated from carbonic acid, is then pushed into the interstitial compartment using the sodium bicarbonate co-transporter, the NBCE, that is the electrogenic sodium bicarbonate co-transporter, which pushes the bicarbonate from the cell inside to the interstitial compartment. And this is how the bicarbonate, which is filtered, is then reclaimed in the proximal tubule. Proximal or type 2 RTA is due to a reduction in the reabsorption of this luminal bicarbonate. As we saw that 80 to 85% of bicarbonate is reabsorbed in the proximal tubule, but in proximal RTA, only about 60 to 65% is reabsorbed. So rest of the bicarb is then delivered to the distal nephron. The distal nephron has a limited capacity to increase the reabsorption of bicarbonate. Instead of 15, maybe 20% will be reabsorbed. So the higher sodium delivery and bicarb delivery in the distal nephron causes salt wasting that stimulates the renin, angiotensin, aldosterone system, and the aldosterone increases the sodium reabsorption at the cost of potassium secretion. And this is the reason why we end up having hypokalemia, because of salt wasting, volume depletion, increased aldosterone, increased sodium reabsorption, and potassium secretion. It is usually an defect associated with generalized problems in reabsorption of different solutes, part of renal Franconis syndrome. Very rarely we may get an isolated proximal or type 2 renal tubular acidosis. It could be a transient or sporadic isolated proximal RTA due to a defect in the sodium hydrogen exchanger, which is on the luminal membrane, responsible for hydrogen secretion and sodium reabsorption. Or it could be an autosomal recessive isolated proximal renal tubular acidosis because of defect in the electrogenic sodium bicarbonate co-transporter. So these are the two important transporters, one on the luminal membrane and other on the basolateral membrane, which can be defective, resulting in isolated proximal renal tubular acidosis. However, proximal RTA is often a part of generalized tubular dysfunction, which we all know as renal Fanconi syndrome. Not only bicarbonate, but even sodium, phosphate, glucose, amino acids, uric acid, all the other solutes are also lost in the urine, and that's how you end up having glucosuria, proteinuria, phosphaturia, and uricosuriya. The presentation of renal Fanconi syndrome depends upon the etiology of its condition. Children with inborn errors of metabolism or storage disorder often present in the first 1 or 2 years of life. Some conditions may present later on depending upon how slowly or how fast there is deposition of the solutes, like late onset cystinosis, Wilson disease, and Den disease. They often present in the later part of first decade, whereas acquired causes can present anytime depending upon the timing and the quantity of exposure to the drugs and toxins. Sodium valproate, ifosfamide, and cisplatin are common examples of drug-induced renal Fanconi syndrome. Certainly, recovery phase of ATN and tubular interstitial nephritis can also cause renal Fanconi syndrome. What is the pathophysiology of renal Fanconi syndrome? The bottom line is a disruption of energy production by the mitochondria. So ATP is not produced. This interferes with the activity of the basolateral sodium-potassium ATPase pump, thereby reducing the activity of the co-transporters, mainly the sodium solute symporter on the apical membrane of the tubular cell. Occasionally, there can be a disruption of endocytic or lysosomal pathway depending upon what condition we are dealing with. Often there is cell apoptosis resulting in a reduction in the number of proximal convoluted tubular cells. Like in the generic form of presentation, children with renal Fanconi syndrome would have growth failure, polyuria, weakness, constipation, and often rickets because of phosphate loss in the urine. Specific to the etiology of renal Fanconi syndrome, children with hereditary fructose intolerance may present with vomiting and flatulence as soon as weaning foods are introduced after 6 months of age. There can be seizures because of hypoglycemia, mental milestone delay because of storage disorders. We may be able to see obvious eye changes, or children with dengue disease may present with gross hematuria. So specific to the etiology, there can be additional presenting features. So to summarize, the pointers towards renal Fanconi syndrome include an acidic urine pH because there is an intact distal nephron hydrogen secretion, iso or hypostenuric urine, often there may be proteinuria or glucosuria, negative urinary anion gap because the distal nephron hydrogen and ammonium secretion is intact, mild metabolic acidemia, usually the potassium is normal or mild. There could be features of biochemical rickets and low absorption. So we are looking at multiple solutes which are lost in the urine, resulting in renal Fanconi syndrome. Do children with renal Fanconi syndrome develop hypercalceuria and nephrocalcinosis? And the answer is usually not. They are not observed, unlike in children with distal RTA. Why is it? There are 3 reasons why children with renal Fanconi syndrome do not develop hypercalceuria. 1, unlike in distal RTA, the metabolic acidemia is of mild severity, and hence there is lower amount of buffering by the bone calcium carbonate. So less calcium is released from the bones along with bicarbonate. Second, as we know, along with other solutes, citrate is also reabsorbed with sodium by sodium citrate symporter. Because of the generalized dysfunction of the proximal tubular transport mechanism, citrate is also not reabsorbed. It is also lost along with proteins, sugar, phosphates, uric acid. So the citrate loss continues in the urine, and as we know, citrate is a natural chelator of calcium and oxalate in our urine. So this prevents formation of hypercalceuria and nephrocalcinosis. And finally, because the urine pH can be brought down below 6, calcium phosphate precipitation can be inhibited. Acidic pH inhibits calcium phosphate precipitation. So for these 3 reasons, nephrocalcinosis is very uncommon. Having said that, when we treat children with phosphate and active vitamin D3 in renal Fanconi syndrome, they can secondarily develop hypercalciuria and nephrocalcinosis. So children on treatment with oral phosphate and active vitamin D3 should be monitored for development of hypercalciuria and nephrocalcinosis. Treatment of renal Fanconi syndrome begins with efforts to identify the etiology. If we can identify the etiology, more than half the battle is won. There are certain rules which we should follow when managing a child with renal tubular acidosis of type 1. These children often have chronic losses. Occasionally, they may have acute losses superimposed by acute gastroenteritis. In that situation, we need to replace parenterally. Otherwise, replace the lost solutes enterally, slowly, small doses frequently to mimic the losses that occur 24/7, and not give a bolus amount of solutes rapidly and then not give anything for the next 8 to 12 hours. And most important for us to remember is not to attempt to normalize the deficiency. It is not only impossible to correct the deficiencies, but it can also lead to increased losses. The more the sodium bicarbonate we give, the more sodium bicarbonate is delivered to the distal nephron, and in presence of hyperaldosteronism because of salt wasting and hypovolemia, the aldosterone will reabsorb sodium and secrete potassium and hydrogen, worsening the hypokalemia. So please watch out for hypokalemia when therapy with alkali is started in children with renal tubular acidosis type 2. General measures include replacement of potassium and alkali, oral phosphate and vitamin D3 when there is hypophosphatemia, dietary measures to reduce hypercalciuria when we start oral phosphate and vitamin D3 therapy, While there are reports of use of hydrochlorothiazide, it's a weak diuretic. If there is no response to above therapy, hydrochlorothiazide will reduce the GFR, lower the filtered load of solutes, and thereby decrease the excretion of the solutes. This has been effective. Only thing is we need to watch out for hypokalemia as a side effect of hydrochlorothiazide. We may use hydrochlorothiazide, but there is no role of ACE inhibitors and ARB in children with renal Franconis syndrome because there is a significant risk of hypotension and AKI precipitation. Treatment of renal Franconis syndrome is very, very difficult. It's like filling a bucket with multiple holes. It is impossible to fill this bucket with water because whatever you give, it's going to keep on leaking out continuously. And hence, while treating a patient with renal Franconis syndrome, we need to have a balance between reduction of the symptoms, desired blood levels, promotion of growth on one hand, and minimization of side effects on the other hand. So this balance is very important. We should not try to shift to one side by giving high amounts of replacement solutes. Moving on to the second type of renal tubular acidosis, which is type 1 or distal RTA. Before we go to distal RTA, let's just recap the way hydrogen is secreted in the distal nephron. As we know, the cortical collecting tubular area has three cell types: the principal, the alpha intercalated cell, and the beta intercalated cells. The principal cell is responsible for sodium reabsorption and potassium secretion. Alpha intercalated cell is responsible for hydrogen secretion, and the beta intercalated cell is responsible for bicarbonate secretion. This becomes dominant in patients with metabolic alkalosis. So what happens in a typical alpha intercalated cell? Similar to the proximal tubular cell, the carbon dioxide is hydrated in presence of carbonic anhydrase isoform 2 to form bicarbonic acid. This dissociates into hydrogen and bicarbonate. Hydrogen is then actively secreted across the luminal membrane through the vacuolar hydrogen ATPase pump. It can also be secreted in exchange for potassium, but this pump is dominant when patients have hypokalemia, so they secrete hydrogen and reabsorb potassium. The bicarbonate, which is formed over here, is then pushed into the interstitial compartment and blood in exchange of chloride by the anion exchanger 1 or the band 3 protein or the chloride bicarbonate exchanger. So there are three major enzymes which are responsible for the secretion of hydrogen over here. Carbonic anhydrase 2, the hydrogen ATPase pump on the luminal membrane, and the anion exchanger pump on the basolateral membrane. What is the pathophysiology of type 1 distal renal tubular acidosis? There could be three defects in distal renal tubular acidosis. One, the secretory defect, or secondary defects either related to voltage defect or the gradient defect. Let me just go through this. The secretory defect could be related to defect in the hydrogen ATPase pump or the hydrogen potassium antiporter on the luminal membrane, or it could be because of a defect in the anion exchanger or the band 3 protein. So any of these three transporters could be defective, and that results in decreased hydrogen secretion in the luminal membrane. That is the primary defect. The secondary defect could be because of voltage defect. In this situation, the problem is with the principal cell of the cortical collecting tubule, there is impaired distal sodium reabsorption. This leads to inability to generate lumen negative potential difference. This leads to reduced potassium and hydrogen secretion and hence hyperkalemia and mild metabolic acidemia. The typical example of voltage defect associated distal RTA is severe volume depletion. You may see children coming with sodiums of 115, 120 and potassium of 7 to 8 because of severe volume depletion. Most of the sodium is reabsorbed in the proximal tubule. Less sodium is delivered to the distal nephron, and hence less sodium is available for reabsorption, and hence less potassium is secreted. all these children need is normal saline bolus followed by normal saline, and within 12 to 24 hours, this electrolytemia is corrected. The third is the gradient defect, which is a membrane permeability defect. In this situation, there are holes which are drilled in on the luminal membrane by amphotericin B, allowing the hydrogen which is secreted into the luminal membrane to back diffuse into the intracellular compartment. The hydrogen concentration in the luminal membrane and the luminal fluid is much higher than in the intracellular compartment. So hydrogen diffuses back down its concentration gradient. Similarly, potassium, which is high intracellularly and low in the luminal fluid, diffuses from the intracellular compartment to the tubular lumen, and hence you get metabolic acidemia and hypokalemia. The typical example of this defect is use of conventional amphotericin B. Please remember, in both the situation, the hydrogen secretion is intact. There is no defect in the hydrogen secretion, but there are other mechanisms which results in mild metabolic acidemia and hypokalemia. So, inherited forms of distal RTA, the secretory defect can be of 4 types. The type 1 is a defect in anion exchanger 1 protein, that is type 1A. This anion exchanger 1 or band 3 protein is also located on RBC, which is involved in chloride bicarbonate exchange inside the cell. It results in hemolytic anemia. It's a milder disease and presents much later in the first decade of life. Type 1B is because of defect in the beta 1 subunit of the vacuolar ATPase gene, which is present not only in the alpha intercalated cells but also in the cochlea. This is a severe presentation, and often these children have deafness in the first 1-2 years of life because of the presence of this vacuolar hydrogen ATPase in the inner ear cells as well. I'm sorry about this. The type 1C is a defect in the alpha 4 subunit of the vacuolar ATPase. This is not present in the cochlear cells, and hence this type of distal RTA is not associated with deafness. And the final one is type 1D, which is related to a defect in the hydrogen potassium ATPase. It's a rare defect, but these patients will have very severe hypokalemia as well. The etiology of distal RTA depends upon whether we are dealing with a primary or a secondary cause. Primary is often isolated and seen in infants. It could be associated with various syndromes. Secondary can be because of interstitial nephritis, autoimmune diseases, or because of medications. Please remember, the primary defect, which is inherited, often presents early in life in the infancy, whereas secondary defects like lupus or Sjogren's syndrome causing secondary distal RTA presents later on in life in an otherwise well-grown child. So a child who is well-grown and presents with features of distal RTA always tend to think about secondary causes, mostly autoimmune diseases. Let me just go through a few differentiating points between distal RTA and proximal RTA. We normally say that rickets are not a feature of distal RTA in young children. However, if we get rickets, it does not rule out distal RTA. We often see rickets in older children with untreated distal renal tubular acidosis. So what are the causes of rickets in distal RTA? There are 3 factors which can contribute to distal RTA and rickets. 1, chronic metabolic acidemia. It inhibits the 1-alpha hydroxylase activity, thereby reducing the concentration of active form of vitamin D, which is the 1,25-dihydroxy vitamin D3. There is significant osteopenia because of loss of calcium from the bones, and there is associated vitamin D deficiency because of decreased oral intake and decreased sunlight exposure related to weakness and limited physical activity. So all of these 3 factors can contribute to rickets and distal RTA. So presence of rickets does not mean we are dealing with renal Franconis syndrome. We can see it in children with distal RTA as well. Why do we get hypercalceuria? It is the opposite of why we do not get in proximal renal tubular acidosis. The severity of our renal acidosis is much more there is more buffering of calcium carbonate from the bones, and hence there is more release of calcium. The proximal tubule is going to reabsorb citrate to compensate for metabolic acidemia, because the citrate gets converted to bicarbonate in the liver. And most important, the high urine pH, because of the primary defect, allows for precipitation of calcium and phosphate. Important pointers, I think, to summarize, it is severe metabolic acidemia, high urine pH, a high or positive urinary anion gap, hypercalceuria, nephrocalcinosis in about 40 to 50%, mild to moderate hypokalemia, and sometimes rickets. The treatment goals are to improve growth, prevent or restrict nephrocalcinosis, prevent and arrest progressive chronic kidney disease, and prevent hypokalemia complications. So these are the treatment goals of a child with distal RTA. The treatment is not only simple, economical, it is also very effective. Much more easier to treat a child with distal RTA than a child with renal Franconis syndrome. We have various preparations which can be used in the management. It could be the tartrate sodium bicarbonate. 250 milligrams provides for 3 milliequivalents of bicarbonate. Potassium citrate, which gives 2 milliequivalents of potassium and 2 milliequivalents of bicarbonate for every 1 ml. Please remember, the citrate here is used for treatment of hypokalemia and metabolic acidosis, whereas potassium chloride, which Dr. Manisha Sahay had mentioned, is used for correction of hypokalemia with metabolic alkalosis, 15 ml giving 20 milliequivalents of potassium. Some important principles of treatment of distal RTA. First and foremost, we should correct hypokalemia without correcting the metabolic acidemia. Child has been surviving with metabolic acidosis for many, many months, whereas treatment of metabolic acidosis without correcting hypokalemia can worsen hypokalemia and can result in cardiac arrhythmias and even that. As we correct acidosis, hydrogen from inside the cell will come out and potassium from the extracellular compartment will go back inside the intracellular compartment, precipitating acute hypokalemia and cardiac arrhythmias. So first, please use potassium chloride when the potassium is less than 3.5. Once it is achieved a normal range, then we can stop potassium chloride and then replace with alkali. Target potassium of 3.725, and resolution of polyuria, polydipsia is an indicator of acceptable potassium level, because the polyuria is because of secondary nephrogenic DI. We should target venous pH of 7.35 to 7.42 and a bicarb of 24, not less than 24. We should not have any concession over here. Inadequate correction of acidemia will result in continuous hypercalceuria, nephrocalcinosis, and future progressive chronic kidney disease, and also will potentiate hypokalemia. So having a target of bicarbonate of 24 is very, very important. We have been taught that the bicarb requirement may be only about 2 to 3 milliequivalents per kilo per day based upon the acid production. But because these children have a significant amount of negative bone calcium content, they would need a higher dose of bicarbonate. Some of them may need even 8 to 10 milliequivalents per kilo per day. Treatment is lifelong, which we can gradually inform the family once we establish a rapport with them. Since non-vegetarian items can generate more acid, we prefer the families to go on a vegetarian diet to generate less acid. Reduce the salt content in the diet, because salt is related with hypercalceuria, and increase the intake of fruits in the child's diet, which is a source of citrate, thereby reducing the requirement of bicarbonate. If rickets are present, we need to treat it with calcium and phosphorus, usually for 2 to 3 months. A cautious use of inactive form of vitamin B3, usually 1 or 2 doses, is sufficient. Certainly the acidemia is also going to help in healing of rickets. Most children will improve biochemically by 3 months and physically by 1 to 2 years. Complications of distal RTA include growth retardation, rickets, hypokalemic periodic paresis, and chronic kidney disease due to nephrocalcinosis and chronic hypokalemia. So to prevent these complications, this children needs to be treated with lifelong intake of potassium citrate and sodium bicarbonate. Last few slides, type 3 RTA, just one slide on this. It's a mixed RTA where there is defect in both carbonic anhydrase isoform 2 in the proximal tubule as well as in the alpha intercalated cells of the distal nephron. So it's a generalized defect in carbonic anhydrase isoform 2. It is not only present in kidney, it is also present in brain and bone. The phenotype includes osteopetrosis, mental retardation, and facial dysmorphism. But the severity of phenotype varies from children to children, and some may have more features of osteopetrosis, some may have more features of mental retardation, and some may have more features of renal tubular acidosis. My final few slides are on hyperkalemic renal tubular acidosis. Again, before we go into the pathophysiology, if we can understand the basic physiology, which Dr. Manisha Sahay has already explained, I will not spend a lot of time, but the principal cell of cortical collecting tubule is responsible for reabsorption of about 5 to 8% of the filtered sodium. This happens because of aldosterone. Aldosterone has three effects. It stimulates the sodium-potassium ATPase, it stimulates the epithelial sodium channel, and it also stimulates the ROMK, which is the renal outer medullary potassium channel. So aldosterone is responsible for reabsorption of sodium down its electrochemical gradient. Because sodium is coming inside, the lumen becomes electronegative. So in order to equalize this, potassium and hydrogen are secreted to maintain electroneutrality. So the sodium reabsorption happens in exchange of potassium and hydrogen. Hyperkalemic renal tubular acidosis could be type 1 voltage dependent, as we discussed earlier, because of severe volume depletion, or it could be type 4 because of hypoaldosteronism. So if you have a patient with metabolic acidemia and hyperkalemia with normal renal function, there are only two possibilities, either aldosterone deficiency or aldosterone resistance. Deficiency because of congenital adrenal hyperplasia, which is the most common type of salt wasting condition in a child, or it could be aldosterone resistance or pseudo hypoaldosteronism. Type 1A, which is because of defect in the mineralocorticoid receptor, it is renal limited and has a good prognosis. Type 1B, it also autosomal recessive mode of inheritance, and it is due to defect in ENaC channel, which is a systemic defect. And type 3, it's an acquired. Type 2 is a misnomer because this condition is associated with hyperkalemia and hypertension. So per se, it is not an RTA, but it is clubbed because of the similarity in pathophysiology. The clinical features are going to be polyuria, polydipsia, vomiting, failure to thrive, recurrent episodes of hyponatremic dehydration, all because of aldosterone deficiency. Aldosterone is responsible for sodium reabsorption and potassium secretion. A child with PUV will present with recurrent UTIs and poor urinary stream. Diagnosis is very easy to make. Acidic pH because of intact distal nephron hydrogen secretion. Negative urinary anion gap.
I found this on the web for us.
Significant hyponatremia, hypochloremia, and hyperkalemia. Look at ultrasound if you are suspecting PUV. Test for CAH and blood aldosterone level if you are suspecting aldosterone deficiency or aldosterone resistance. Treatment is salt, salt, and salt. These children respond very, very nicely to sodium supplementation. We do not need to give them 3% sodium chloride. All we need to give them is normal saline bolus followed by normal saline IV, and then oral salt solution, potassium binders, and oral fludrocortisone and hydrocortisone if we are dealing with CAH. If it's aldosterone resistance, we need to give them very, very high doses of salt, low potassium diet, and potassium binders. Final two slides. How do we approach a child with suspected renal tubulopathy? If we have a child with failure to thrive, polyuria, and polydipsia, first we need to make sure we are not dealing with chronic kidney disease because of hypodysplasia or PUV based on renal function 10 ultrasound. We need 3 steps. Complete urine examination, arterial blood gas or venous blood gas, and serum electrolytes. If the pH is less than 7.35, we look at renal tubular acidosis. If it's alkalemia, we think about Barter Syndrome or Kittelman Syndrome. Whereas if the pH is normal, we think about diabetes insipidus. So I would like to summarize my talk by saying that renal tubular disorders should be suspected in a child with failure to thrive, polyuria, and polydipsia, after excluding chronic kidney disease due to hypodysplasia and POV. A detailed history beginning with birth weight, amniotic fluid index is the most important tool. Investigation should begin with complete urine examination, spot urine electrolytes, venous blood gas, renal function test, and ultrasound abdomen. Diagnosis is usually very easily made. The treatment is effective, economical, decreases morbidity, and ultimately prevents progressive chronic kidney disease, especially in children with distal acidosis. I would like to stop over here and once again thank the team for the wonderful opportunity. Thank you.
Thank you so much, sir. Firstly, dealing with acid-based disorders is very difficult, and it means it's very volatile as well. Thank you for fine-tuning the many segments of renal tubular acidosis. We just have 2 questions now. It was initially just a comment. It was an excellent presentation. The next question is to Dr. Mehul Shah. So can we take up the questions?
Yes, please. Yes, please.
How good is urine anion gap in differentiating between proximal and distal renal tubular acidosis? Recent review says that even proximal renal tubular acidosis urine anion gap can be positive or even negative if it is borderline. What is your comment on that, sir?
Yes, I think that is true. Because of lack of time, this is a very extensive topic. Any test which we obtain in medicine is going to have its limitations. So we need to, there are factors which can affect the urinary anion gap. So there could be reasons why the urinary anion gap could be positive in a child with renal tubular proximal acidosis, and that is true. But for most children, when it's an isolated renal Franconis syndrome without any additional diarrhea or vomiting or use of medications, the urinary anion gap is going to be close to 0 or negative, which would mean that there is adequate ammonium. But yeah, there can be situations where there can be positive, there can be negative, there can be positive urinary anion gap, which would mean that there is a defect in ammonium. But for practical purpose, it is simple. This would actually not even be required, because in a child who has got a renal Fanconi syndrome, you would often find trace proteinuria or protein creatinine ratio which is high. There would be some glucoseuria, there would be hyperuricosuriya. Metabolic acidemia is mild. So the most situations, to be honest, we don't have to go to even urinary anion gap. But if we get it, it's usually negative in proximal RTA, which means that there is enough ammonium, and it is positive, which means there is inadequate ammonium in the distal nephron. But there can be exceptions, and we need to be aware about it. That is possible. That's true.
Thank you for the wonderful explanation, sir. The next question is, in PHA type 1, what is the prescribed dose of salt you would advise?
Yeah, ideally we need to see the most children with PHA would present in the first 1 year of life with recurrent episodes of dehydration and hyponatremia. And as we know that breast milk contains very minimal amount of sodium to the extent of 5 to 10 milliequivalents per liter, these children would be losing a lot of sodium. So theoretically, we can measure the urinary sodium concentration and roughly estimate the volume of urine the child is passing per day by weighing the diaper. So we can get the total amount of salt which the child is losing, which is little cumbersome. So what we do is we feed these children with about 8 to 10 milliequivalents per kilo of sodium per day. And how do we do that? We give children 3% sodium chloride, which is used as a parenteral fluid. We use that as an oral salt supplementation in children less than 6 months of age. And once they are more than 6 months, we roughly ask the children to add, the families to add extra salt in the weaning fluids. We have had 9 children with PHA type 1 and 2 with type 1B. And all these children have done extremely well because it's a self-limiting condition because of maturation of the mineralocorticoid receptor. And these children do fine by 2 years of age. So it is a rough estimation. We give about 8 to 10 milliequivalents per kilo per day of sodium in form of 3% sodium chloride orally. Once the child is on weaning fluids, we ask the family to put extra salt in the weaning fluid, avoid potassium. If you want to be more precise, we need to check a random sample of urine for sodium and then weigh the diapers of the baby over 24 hours and then estimate the 24 hours urine sodium excretion and then replace that. That is more cumbersome, but that is theoretically more valid. I hope I'm clear.
Okay, fine, sir. And so the next question is again to Dr. Mehul Shah. What is the role of genetic testing in renal tubular acidosis and prognosis of cystinosis in children?
The genetic testing for renal tubular acidosis, if we look at distal renal tubular acidosis, the diagnosis is very clear. As Dr. Manisha Sahay had also mentioned that the diagnosis, for confirmation, it can help us. More for prenatal diagnosis for subsequent pregnancy, it is going to be helpful when we are dealing with distal RTA or with hyperkalemic type 4 RTA, so that we can counsel the family whether the next child is going to be affected or not affected. That is for the subsequent pregnancy for type 1 and type 4. Now coming for type 1 RTA, which is the renal Franconis syndrome, many times we may not be able to identify the etiology. So if we can get a panel of tests done to identify the cause of renal Franconis syndrome, we will be able to direct a specific therapy. Suppose if it's for tyrosinemia, or it is with galactosemia, or it is with glycogen storage disorder, or Fanconi-Bickel syndrome. So yes, in those situations, I feel the genetic mutation analysis is much more useful in the index patient. The second advantage is in the subsequent pregnancy, we will be able to do a prenatal diagnosis to see whether the fetus is affected or not. That is second. Third thing is regarding the cystinosis. Definitely, it is the most common cause of renal Fanconi syndrome. Relatively easy to diagnose, difficult to treat, and most children with cystinosis, especially those being present in the first 1 or 2 years of life, called as a nephropathic cystinosis, they will progress to end-stage renal disease by 10 to 15 years of age. They will have systemic manifestations of cystinosis in terms of muscle weakness, hypothyroidism, eye changes. Although we may be able to treat the ESRD by renal replacement therapy, the systemic effects are not significantly modified by renal replacement therapy unless we use cysteamine for them, which is very difficult to obtain in our country. It has got a lot of GI side effects and it has to be given 4 or 5 times in a day. So the prognosis per se is not very good in children with infantile or nephropathic cystinosis. There is a third variety of late onset childhood cystinosis, which is a milder variety, and those children do much better with a very slow progression of kidney disease, and in fact they don't develop kidney failure.
Okay, fine. Thank you so much, sir. And the next question is again to Dr. Mehul Shah. Can you tell something about the frusemide challenge test?
Yes, I don't know whether I can do justice over 1 minute, but basically what we are trying to do over here is, as Dr. Manisha Sahay has also mentioned, I think understanding the physiology really makes it easy for us to understand the pathophysiology and the tests behind all this renal tubular disorders. So what happens in renal tubular acidosis? There is some degree of volume depletion, increased sodium loss, increased aldosterone. So when we give furosemide, what are we doing? We are blocking 25% of sodium chloride reabsorption in the medullary thick concerning limb of loop of Henle. So we are blocking that. So we are increasing the delivery of sodium chloride to the distal nephron, which is the cortical collecting tubule. Now, if these patients have distal RTA, what is going to happen? Sodium is going to be reabsorbed with more potassium secretion. The hypokalemia will be worsened and the urine pH is not going to increase because there's a defect in hydrogen secretion. When aldosterone is acting in the distal nephron, it reabsorbs sodium and secretes potassium and hydrogen. So when we give furosemide, we are increasing sodium delivery. We should be able to reabsorb sodium because aldosterone is there and secrete potassium and hydrogen. But in distal RTA, because the hydrogen secretion is a basic defect, the hydrogen secretion will not take place and the urine pH will remain high. Whereas if a patient has got an intact alpha intercalated cell, sodium will be reabsorbed in exchange for potassium and hydrogen. So your hydrogen goes into the lumen, that will decrease the urine pH. So a furosemide challenge test is increasing the delivery of sodium and seeing whether hydrogen secretion takes place or does not take place. And how do we assess that? By urine pH. I don't know if I have a tubule in front of me, it becomes a little easy, but that's the basic principle. You are increasing sodium delivery at distal nephron and then letting aldosterone secrete more potassium and hydrogen. So if there is hydrogen secretion defect, hydrogen will not be secreted, and hence the urine pH is going to be high. Whereas if it's a proximal RTA, hydrogen secretion will happen and your urine pH is going to be low.
So you cannot understand renal tubular acidosis, as Dr. Mehul said, without understanding the renal physiology. And renal tubular acidosis is a very, very hot topic for the exams. It's always, if it's there, it's a short case. And renal tubular acidosis is, yes, so it's a very, very much scary case for people who don't see it frequently. And you, as rightly pointed out, that understanding physiology is important. So these common questions, what are being asked, Dr. Mehul, are the questions which are often asked by the examiners as well. So the furosemide challenge test is asked, and then about the types of proximal RTA where the urine pH is high. So just to emphasize that you should do you should rule out a urine infection before you comment on the urine pH and all that. So those things are frequently asked. And you made a point that rickets, generally distal RTA, in very young children, we don't see rickets. But in our analysis of around 130 children of rickets, the most common cause of rickets was distal RTA. So probably they were older children. So we had distal RTA and hypophosphatemic rickets. So they were the common varieties, and the other ones were less common. So this is and in adults, generally what we find is the most common cause of distal RTA is Sjogren's syndrome. So 50% of distal RTA in adults is Sjogren's syndrome unless proved otherwise. Similarly, in proximal RTA, the most common cause of proximal RTA in an adult, we find we should never forget about multiple myeloma. We find about multiple myeloma in that manner. So renal tubular acidosis is a very extensive topic, and I think you have done very great justice to the topic, highlighting all the principles of treatment. And I'm sure there would be hundreds of questions on renal tubular acidosis. So I think the basic message is the physiology should be clear. Otherwise, you cannot mug it all up. It's not possible.
That's true.
And it's so volatile as well, ma'am.
Yes.
The next question is again to Dr. Mehul Shah. Hope you don't mind taking so many questions, sir.
Absolutely. And Dr. Manisha will help me out, so she can help me out. Yeah.
What is the association between renal tubular acidosis and nephrotic syndrome? Is there really any association?
I don't think there's a different relationship between RT and nephrotic syndrome, because both of them, the pathology and pathophysiology is different. Nephrotic syndrome is a glomerular basement membrane defect or a problem, and RTA is a proximal tubular or a distal renal tubular cell problem. So I'm not sure whether, at least I'm not aware if there's an association between the two. Manisha, do you feel, is there any association between the two?
In some articles in literature, it is said in steroid-resistant nephrotic syndrome or FSGS, the proteinuria leads to a dysfunction of the tubule. So probably the person who is asking those questions in some of the literature articles, nephrotic syndrome has been mentioned as a cause of secondary RTA, proximal RTA. So we don't find it very frequently. We have never seen it, but it's mentioned in some of the papers because of that ongoing proteinuria that may cause tubular damage is one of the mechanisms postulated. But clinically, we have never seen any such case.
And because by the time it develops, it would have been an established CKD, and that's what we mentioned, that once a child develops CKD, we cannot use the word renal tubular acidosis. It would be acidosis of CKD. If I can just add on to this, Manisha, that's an important point. In children with Dent disease, the defect in the chloride channel, the CLC-NB channel, can be associated with proteinuria, but it is not extensive that it causes nephrotic syndrome, because the same transporter is located on the podocyte as well, not only in the endosome, but also on the podocyte. But per se, as we said, no direct correlation that I'm aware about.
And that is low molecular weight proteinuria in density.
Yes, exactly. That's right. Exactly correct.
So the next question is again to Dr. Mehul Shah. Does racial background affects the severity of distal renal tubular acidosis?
I don't think so. I think it's ultimately the type of mutation which is associated with the phenotypic presentation, not the racial background. Certainly, certain mutations are more common in certain ethnic groups as compared to in others. So I think it depends upon the different types of mutation. As Dr. Manisha Sahay said, whether it's a splice mutation or it's a deletion or whatever it may be there. So certain types of mutations are known to present with more severe phenotype as compared to others. But I'm not aware whether a particular racial group is associated with significant severity of renal tubular acidosis. It may be associated through a specific mutation type rather than a direct phenotypic association.
Okay, fine, sir. And the next question is to Dr. Manisha Sahay. How do we differentiate the pseudo-Barter syndrome?
So that's what I was trying to explain. Throughout the talk is finally, the term pseudo-Barter syndrome is used in different meaning in different articles. So generally, to Barter syndrome, you will have a high urine chloride, whereas in the other Barter syndrome, that manifestation won't be there. And as I was showing in that paper, even some cases of cystic fibrosis have been clubbed under pseudo-Barter syndrome. Then you have other extrarenal causes of chloride loss, which have been clubbed under pseudo-Barter syndrome. So urine chloride would differentiate. And finally, the definitive diagnosis would be by genetic analysis, as in the paper from that orphanate registry, where they have put everything as Barter syndrome, but genetic analysis showed in 25% it was pseudo-Barters, and it was Pendred syndrome in some, cystic fibrosis in another, and apparent mineralocorticoid excess in another. So again, looking at the urine chloride, looking at all the other features, and ultimately the genetic diagnosis helps there.
Okay, thank you, ma'am. Next question is to Dr. Mehul Shah. Sodium citrate used in which situations in place of potassium citrate?
I think in most situations, we would prefer using potassium citrate and not sodium citrate, because we know we want to reduce the sodium intake to reduce the hypercalceuria in children with Barter syndrome. So the only time we would replace potassium citrate with sodium citrate is when there is progressive chronic kidney disease, and we would be worried about hyperkalemia developing because of CKD. In those situations, we would use either sodium citrate or more commonly sodium bicarbonate, which is available, rather than potassium citrate. But if available, we would be using potassium citrate more. If it's not available, there is a combination Scholl solution which we used to prepare with sodium citrate, but that provides more sodium, and more sodium will contribute to hypercalceuria. So if we can have potassium containing alkali solutions, we should prefer that, except when there is increasing serum creatinine. In that situation, we should replace it with sodium citrate.
Okay, fine. Thank you, sir. And the next question is to Dr. Manisha Sahay. In Barter syndrome, do we use thiazides to treat hypercalceuria?
See, again, it's a double-edged sword in Barter syndrome. And again, that is one of the mechanisms explained, but you have to take care that the child doesn't go into volume depletion. Similar thing holds true in RTAs as well. Sorry. So RTAs as well, and thiazides in addition cause metabolic alkalosis, which worsens that metabolic problem. So those things we have to keep in mind, provided you are able to correct the metabolic milieu by using other therapies. You can add thiazides to the regime, but it is a double-edged sword, as I said.
Okay, fine, ma'am. And the next question is, the question is not all that clear. Have a case of distal renal tubular acidosis with HBD Punjab heterozygous anemia, any association? I'm not sure about the question.
Yeah, so I don't know whether it's a kind of, I think it could be a kind of a mild hemolytic anemia, and that is seen in
Okay.
children who have got the anion exchanger 1 or the band 3 protein or the chloride bicarbonate exchanger defect, because this chloride bicarbonate exchanger is located not only on the basolateral membrane of alpha intercalated cells but also on the RBC membrane. How do we transport carbon dioxide? And that is one of the important transporter on the RBC membrane to exchange carbon dioxide. So when we have the anion exchange 1 defect, autosomal dominant type, we can have a mild degree of hemolytic anemia. So we not only look at the CPP once in a year in older children, we also look at the LFTs, and many times you will feel that they have this mild hyperbilirubinemia of the indirect variety. There is no specific treatment for that. It's not usually a progressive condition. I'm not sure whether this particular phenotype of anemia is the same type which the member is asking for. But yes, the association is with anion exchanger 1 or chloride bicarbonate exchanger defect.
Okay, fine. And next is rather a comment. It is one of the best presentations on Barter syndrome and renal tubular acidosis. And the next question is there any kind of relationship between urea cycle disorders and renal tubular acidosis?
Oh my, that's a tough one. Not that I have come across an association between these two, but physiology and pathophysiologically, we know that in renal tubular acidosis, there is going to be increased production of ammonia by the proximal tubular cells. And whether as part of that, meaning ammonia is going to come from urea, because it's 2 molecules of ammonia is there in a urea molecule. So whether that is associated with increased urea production, and RTA with severe variety can be associated with high ammonia and high urea. I'm not sure about it. Not that I have come across it. So I'll need to refer to the literature for that. Manisha, do you have any comments on that?
No, I guess, I mean, you are a more pediatric nephro person, and I think I fully agree with whatever you said. I was just thinking about the other question, that nephrotic syndrome with tubular disorder. One thing what we could have, I mean, that presentation may occur is patients of SLE, where they can have a tubular defect and a glomerular disease as well. So
Correct.
I mean, we forgot to mention, but we have few cases where we had, I mean, the glomerular and tubular defect coexisting in the same patient.
Yes.
Yeah, but
just
the urea cycle, yeah, I mean, I fully agree with what you explained.
Okay, fine. The next question is for urinary pH measurement, is early morning first and second urine sample advisable?
Yes, it's always suggested to take the first morning fasting sample, because diet is going to modify the urine pH. As we said that if you are on high salt diet, high non-veg items, lack of fruits and vegetables, or increased fruits and vegetables, all of them are going to affect your urine pH. So preferably the first morning urine pH, and that too the sample has to be collected in a syringe. It has to be kept to prevent evaporation of your carbon dioxide. Earlier, we used to collect the urine sample under paraffin oil to prevent evaporation of carbon dioxide. But otherwise, we collect like a venous blood gas and then check the urine pH using a pH meter, not with the heuristics, because the heuristics is not very accurate. So we need to use a pH meter in a freshly collected sample in a sealed syringe to check the pH, and preferably the first morning sample, to minimize the effect of dietary intake on the urine pH.
And just to add to what Dr. Mehul said, it would be a good point to visit your laboratory once and see how these things are done. Because it's very commonly asked on an exam also, when I ask what is the normal range of urine pH, I'm so surprised to get the answer 6 to 7, 6 to 8. Urine pH has a very wide range in contrast to the blood pH. The urine pH undergoes all that, variation from 4.5 to 8 to maintain the blood pH within a narrow limit. So these things, the laboratory visit is definitely important for all the pediatric postgraduates, nephro postgraduates as well. I mean, how do you test the urine specific gravity? So people don't know that you can test it with a small drop of urine. So those things are important. How to collect samples for pH, I think, just to add to what Dr. Mehul said already. Because
Yes.
those questions are also asked in the case of RTA. RTA is
Right.
examiner's favorite case and a nightmare
Okay.
for the student.
Right.
Okay, thank you so much, ma'am. The next question is again to Dr. Manisha Sahay. In early presentation of Barter syndrome, can alkalose be absent? But genetic evaluation showed Barter's mutation, but no
That's very
alkalosis.
true. So that's very true. So as I said, in one of the case reports, they have shown that metabolic alkalosis was mild, and in another case report, it was absent. But some of these manifestations develop over a period of time. So that's why medicine is an art and a science as well. So some manifestations develop over some period of time. You have to take the whole picture into account. I mean, if you have a presentation like polyhydramnios, polyuria, failure to thrive, you have hypokalemia. So you have to keep the entire picture in mind. Sometimes, as I said, the initial diagnosis was nephrogenic diabetes insipidus, turned out to be Barter syndrome. So similarly, and some of the tubular defects, I mean, you may have double mutations as well. In one of the other reports, there was a mutation in the Barter gene as well as the aquaporin gene. So these problems do occur, and in these cases, the picture evolves over a period of time. So probably you may end up misdiagnosing the case early on. But as I said, the most consistent abnormalities are metabolic alkalosis and hypokalemia. Though in medicine, nothing is 100%. So still, you have to, I mean, put the children on follow-up. If you are not able to make a specific diagnosis right away, it would be worth your while trying to correct the internal milieu of the child. And you may be able to make a diagnosis after repeat measurements over a period of time. So I hope that answers your question.
Yeah. If I can just add on, that's absolutely wonderful, Manisha. There has been an association, especially with type 2 Barter syndrome, where there is a defect in the renal outer medullary potassium channel on the luminal membrane of thick ascending limb of loop of Henle, as well as on the principal cell of the cortical collecting tubule. So when there's a defect in type 2, because it's the ROMK channel which is responsible for potassium secretion in the distal nephron, as you had very nicely explained, in presence of hyperaldosteronism. So when children are born prematurely because of severe polyhydramnios in type 2 Barter syndrome, because the ROMK channel is also defective, the potassium is not secreted in the first few weeks of life, and in fact they may present like a pseudo hypoaldosteronism, meaning the aldosterone is there, but because the ROMK channel is not there, potassium is not secreted, and they will be having hyperkalemia. But as the child grows and the renal tubular function matures, there will be some other potassium channels which come out in the cortical collecting cells, mainly the maxi potassium channels, and that's how the potassium starts coming out in the urine, and then the typical manifestations of hypokalemic metabolic alkalosis shows up after 2 to 3 weeks, especially with type 2 Barter syndrome. That's true.
Thank you for that input as well, Dr. Mehul.
Thank you. And the next question is again to Dr. I think it's a very common question. How sodium reduces hypercalceuria?
That's it's a very important question, and let me just go back. As we said, the proximal renal tubular function, it's a leaky tubule. It's a workhorse of the kidney. It reabsorbs most of the solutes which are filtered at the glomerular basement membrane. So how does sodium reabsorb hypercalceuria? It's basically, as we have seen, that sodium and various solutes move from luminal membrane inside the cell, from luminal membrane intracellularly. So as the solutes are going from lumen to the inside of the cell, the water also flows along with it, because water flows from a concentration of high concentration to low concentration. So as solutes are moving, water has to go, because now the water content is going to be high. The water goes through aquaporin channels on the luminal membrane. So when water and solutes are reabsorbed, what happens to the amount of calcium, uric acid which is in the lumen? The concentration relatively increases. So when the concentration increases, calcium goes through the paracellular pathway from the lumen into the interstitium. So that is how 70% of calcium is reabsorbed in the proximal tubule. Same way as 20% is reabsorbed in the thick ascending limb of loop of Henle And that's how we get Barter syndrome. It is the relative increase in the concentration of sodium when salt and water is reabsorbed. So that's how there is a passive diffusion from high concentration inside the lumen to the interstitium where the calcium concentration is less. So that is the basic physiology. So now what happens in sodium when you eat a lot of salt, which all of us are doing, unfortunately, our body is going to reabsorb salt as much as we need. The rest of the salt is going to excrete. So as Dr. Manisha Sahay said, there's nothing like a fixed urinary pH value. There is no fixed urinary sodium concentration. It depends upon the volume status and it depends upon how much salt we are taking. So if you take more salt, that extra salt is going to be excreted in the urine because nature does not want us to develop hypertension. So that's how we will lose extra salt. So when sodium is going to come out, sodium chloride and water comes out, less calcium is going to be reabsorbed. And hence more calcium comes out in the urine because 70% of calcium is reabsorbed passively through the paracellular pathway in the proximal tubule. Conversely, let me put it other way. If you are on a low salt diet, most of the salt, 80% of the salt is going to be reabsorbed in the proximal tubule. So along with salt, water is going to be reabsorbed. Calcium is going to be reabsorbed passively from a higher concentration in the lumen to the lower concentration in the interstitium. And hence less calcium will come down the tubule into the urine. So low salt diet, increased calcium reabsorption in the proximal tubule, paracellular pathway, and less calcium in the urine. High salt diet, high salt excretion, less calcium reabsorption and hypercalceuria. I don't know if I'm clear on this point, but the calcium reabsorption is a passive mechanism related to sodium chloride and water reabsorption in the proximal tubule. So the more salt we take, that extra salt comes out in the urine. If we take 10 grams of salt, our body needs 2 grams. We are not going to reabsorb 10 grams of salt because we will develop hypertension. So nature is going to let go 8 grams of salt. So along with that 8 grams of salt, other solutes are also going to come out, predominantly calcium, uric acid, water. And that's how high salt diet is associated with hypercalceuria. And that is the reason why we give normal saline bolus in patients with hypercalcemia. When we are giving normal saline bolus, we are expanding the intravascular volume. We are decreasing the renin, angiotensin, aldosterone system. Angiotensin 2 is also responsible for sodium reabsorption in the proximal tubule. It has an effect on the sodium hydrogen antiporter. So less sodium is reabsorbed, and along with less sodium, calcium comes out in the urine, and thereby you are decreasing the blood calcium level. So please remember hypercalcemia. One of the first treatment is giving saline diuresis. You are increasing the sodium delivery to the proximal tubule. It does not get reabsorbed, and along with sodium, calcium comes out in the urine.
Okay, fine. Thank you, sir. And the next question is again to Dr. Mehul Shah. Is there any association between hyperrenism and Fanconi syndrome?
Yes, I think it's a direct correlation because all patients with Fanconi syndrome or renal tubular acidosis are going to have some amount of salt wasting. So salt wasting is going to result in mild hypovolemia, decreased intravascular volume. And decreased intravascular volume is going to stimulate renin, which is going to stimulate aldosterone 2, and which is going to stimulate angiotensin. Sorry, renin, angiotensin 2 and aldosterone. So yes, all patients with Fanconi syndrome will have hyperrenism. Children with distal RTA will have a higher level of renin secretion because they are more volume depleted as compared to Fanconi syndrome. So yes, it is there. Okay. And this hyperrenism will worsen when you treat them with soda bicarb, because that's what we said. When you treat them with soda bicarb, there is more filtration, more loss of sodium bicarbonate, more volume depletion, more renin, aldosterone, and more hypokalemia. So it is mild to begin with. It worsens when we treat them with sodium bicarbonate.
Okay.
I think it seems to be little okay.
It was an excellent presentation, sir. I think whatever comments I wanted to say, like it was almost given by the participants. There are last few comments. The comment was excellent presentation. Next was a wonderful presentation. And the last but not the least, it was wonderful explanation by Dr. Mehul Shah, demystifying the tubules for us. I think the physiology of tubules is being dealt very well by Dr. Mehul Shah and Dr. Manisha. It was a wonderful presentation. Thank you so much. I think we are done with all the questions.
Thank you. Thank you.
Thank you so much, sir. It was an excellent presentation. Thank you for chairing the session, madam. Thank you so much.
Thank you, Manisha. Thank you, Dr. Ganesan. It was wonderful. And thank you to your audience. Yeah, it was wonderful learning experience. Thank you.
Thank you. Thank you so much, madam. Bye-bye. Thank you, sir.
Take care.
Bye.
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 Bye. Bye, Dr. Ganesan. Bye.